Hello everyone, this is Shadi Reis from CVI in Austin, Texas. I'm really privileged today to be with Dr. Abdallah El Sabbagh. He is an interventional and structural interventionist at Mayo Clinic in Jacksonville. Abdullah, always nice to see you.
Thank you so much, Shadi. Thank you for having me here.
So we are in the CVI, and it's standing for innovation, and we always look for new ways, transcatheter-based therapies for patients with different cardiac diseases. And lately, you shared with us that you have some new innovative way to approach infective endocarditis of the right side. So tell us about some background of this work.
Yes, absolutely. So the whole story with percutaneous options in infective endocarditis started with the epidemic or the big problem that we face in this country, which is the IV drug use. And that really, these patients unfortunately come in with large tricuspid valve vegetations. Historically, it was antibiotics plus surgery. And what ends up happening is the valve gets replaced, but the IV drug use continues, and they come back with an infective prosthesis. And it really puts the surgical, as well as the whole medical team, and even on a financial and economical basis, it puts a big strain on the system.
Absolutely.
And so with the advent and with the evolution of the PE interventions, which is pulmonary embolism, and with the aspiration devices that were created for that purpose, there was an extension or extrapolation of use of these devices to take out the vegetation with the purpose of debulking it and increasing the antibiotic efficacy by debulking the vegetation and also lowering the embolic risk.
Right.
And so, and it's been growing in a popular way, and more and more adoption of it as the front line of approach to treat these patients. Of course, it's an area of more data that's emerging. We have 2 registries, a couple of series, and now a multi-center registry. So we'll have more data.
Absolutely. So what is your ideal candidate for these therapies?
Absolutely. So the ideal candidate is a patient with infective endocarditis on the atrial side of the tricuspid valve that's large, mobile, and it's in an acute setting. So the unfavorable anatomies, so we look at 3 things. We look at the vegetation, we look at the patient, and we actually look at the location, right? So if it's on the atrial side, bacterial vegetation that's large, that's favorable. If it's chronic, calcified, fungal, the fungal ones tend to recur, and if they systemically get showered, they can cause systemic fungema, which is a big problem. And then we look at the patient, and there's the series showing that patients who present with septic shock, they actually don't do so well, even if we aspirate the vegetation. So those in septic shock may not be the best candidates for it.
So when do you consider them, or is it like a multidisciplinary approach with a surgeon? Surgeon would say this patient not a candidate for surgery, or usually even if the patient is candidate, you still transcatheter an option?
That's a great question. So this is where the endocarditis teams have emerged again and expanded. So now there's a surgeon, ID, sometimes neurology, and now an interventional cardiologist and a non-invasive cardiologist on the team.
To help with the imaging.
And we discuss every patient. So surgeons are not excited about operating in these situations. So I think they've more and more adopted these procedures.
And you mentioned something about the registries. Are these created to have a follow-up of these patients?
So this is the chance. So the first registry that is largest was the rapid registry, which included clot plus, and there was about 40-something vegetations. Okay. The other registry was in patients with device-related endocarditis, so aspiration and removing the lead, it just enhances the safety because septic emboli is not a good thing. It has negative consequences. The problem with follow-up is with IV drug use, patients, the follow-up is going to be very difficult. So the ideal trial, and it is ongoing, it's starting and ongoing, is going to be in the device-related endocarditis.
Okay.
Because they all come back for device check.
Exactly.
And so
that would be easy to track.
Correct.
Final question is, from your registry, on your experience, these patients clear up the blood cultures after removal of this bulky vegetation?
Correct. So most of these, so there's different, I wouldn't say indications because again, we're waiting for the data, but reasons would be persistent sepsis, and they usually clear. We call success if 70% or more of the vegetation is debulked, or if they've had recurrent embolism despite antibiotics. That's another reason. And then obviously IV drug use upfront is another reason for that, and also sometimes for diagnostic purposes, because we get the tissue, and often the organism in the blood is underrepresented, and we see more organisms because these patients can have multi-organism endocarditis because they have saliva on the needle and they inject themselves.
That's correct. Yeah.
So those are the reasons, and we've seen success with it, and we've seen it stop the sepsis. Now, it's not in every patient. Sometimes we have to go back in, and if there's a sessile component to it, we try to snare what's left while suctioning, but that can be messy.
In summary, now we have a shock team, we have PERT team, and we have infective endocarditis team.
Exactly, that's exactly right.
That's a new cocktail
New
physician.
Yeah, that's the way to go.
That is, yeah. Abdallah, thanks for sharing this great experience.
Thank you for having me.
Please watch these videos and others on CVI YouTube channel. This is Shadi Reis from Austin. Thank you so much, Abdallah.
Thank you so much.